Hi, everyone. Thank you so much for taking a few minutes to view this presentation, this applied learning case, focused on engaging with leaders and others within health systems. My name is Josh Johnson. I am a physical therapist and an assistant professor in the Cleveland Clinic LeaRRn College of Medicine and the director of outcomes research in the Department of Physical Medicine and Rehabilitation at Cleveland Clinic. For this learning case, I want to share with you today just a bit about what we're doing in learning communities at Cleveland Clinic to drive our rehabilitation-focused learning health system. To do that, I'm going to highlight one example of a project we recently completed and are still in the midst of, in some ways, related to acute care physical therapist practice and discharges home. Just as a disclaimer as I get started, this entire presentation is obviously from my perspective, and my perspective is as the researcher within this learning health system. The learning health system is driven by so many of us, including our health system leaders in rehabilitation and outside of rehabilitation, but it'll be clear that my perspective is as the researcher as we go through this. So just a quick note that our learning health system is really focused on driving higher value care. And therefore, our intention is to improve health outcomes that matter to patients at costs that are sustainable or even less than current state for our health systems and for our patients. And it's through that lens that we approach everything we do, including the project I'll present today. Oftentimes, we have the opportunity to take on projects that intersect both with higher value care and with the priorities of our health system leaders. And this was an example of that. Everything we do within learning health system cycles. And so for those of you who have not yet seen this figure or a figure like it, this really is the framework of our work. So you'll notice that in the middle, there's a health problem of interest. So this health problem is identified, and then there's a decision to do something about it, to study it. The very first step is the formation of a learning community, which I'll talk about a little more at the end of this slide. From there, it goes into three separate stages. The first is performance to data, where you capture practice as data. This is usually done through the electronic health record. And then you assemble and analyze that data as part of this data to knowledge phase. Where you have any external evidence to inform practice changes, you incorporate that at this point with your internal data as you're trying to derive new knowledge that relates to your health problem of interest. You interpret those results, then you can design an intervention and take action in this K2P or knowledge to performance phase. Again, the key to this is really the formation of a learning community. None of this should be done in a silo or in a vacuum. You need all of the right people at the table to discuss and solve the problem. And so that's the goal of the learning community, is having a multidisciplinary group of individuals who have a shared interest and common goal of addressing this problem, but have varying expertise and experience so that you have more richness to your group as you try to solve this problem. And this really is a key to engaging within health systems, whether that's engaging leaders, engaging clinicians, or other partners that need to be part of solving this health problem of interest. And so you'll note that everything that I present today, I'll highlight the specific role of the learning community as the key to engagement. So this particular problem actually started at the top of our organization. This became an organizational priority for us in 2021. As one of our drive metrics, our CEO and others at the executive level of the Cleveland Clinic identified that we needed to be able to discharge more patients home, either with or without home health care. So this slide came from Dr. Leslie Jarecko and was presented in several meetings across the organization as we kicked off 2021. Dr. Jarecko is our Chief Safety and Quality Officer. So this was obviously an opportunity we felt in rehabilitation to directly affect a measure that was a drive metric for our health system. So again, if you think about that learning health system cycle where we are attempting to identify a problem, first came defining the problem. And this work was initiated by senior leaders in rehabilitation, Dr. Mary Stoff and Dr. Karen Green, who are our senior director of all of rehab services and our director for acute care therapy services. And so in partnership with Mary and with Karen, we identified ways that we might study this particular issue and ways that we in rehabilitation might impact and influence the ability for more patients to discharge home. So we had a clinical problem, and the priority of our leaders, as it was stated, was that we needed to better understand if and how we help patients to discharge home from the hospital. So again, in collaboration with these leaders, I sat down and we drafted some study aims. The first was to describe in-hospital PT utilization and related outcomes. This was really because we didn't know exactly what our impact was, and we needed to understand it. So that really lent to a descriptive study. So we aimed for a broad description, and we looked at across all Cleveland Clinic hospitals so that we could go back to leaders and help them to understand what was currently happening in their local practice. The second aim was to examine the relationship between physical therapy frequency with two outcomes in particular, improved function and discharge home. This was to get at that second part of their priority. How, or if and how do we impact discharge disposition, specifically discharge home? So the rationale for this aim was to determine if there was some association between physical therapy and outcomes that are considered important to patients, and then inform future directions and things we needed to do next to really get at the how do we change this outcome. So again, thinking back to our learning health system cycle, we had defined our problem and now had some specific aims as research to guide our research, And next was to form our learning community. I wish I had had the foresight to take a picture of this group. I didn't. So we're stuck with this screenshot of our Microsoft Teams learning community. But you'll note here that there are multiple people and roles represented. So we opted for the first part of this problem to focus on physical therapy interventions in the hospital. So we found a group of physical therapists who could be engaged. So myself as the researcher, we actually hired a staff physical therapist to be a research assistant on this study. And then we had 3 department leaders, specifically at one of our hospitals, and then 4 additional staff physical therapists. And these physical therapists were selected for a few reasons. One, they represented a group of individuals who are really driven to change patient outcomes. And they've demonstrated that consistently in their practice and in the way that they interact with their colleagues, both other therapists and physicians and nurses and others in the hospital. This group also has diverse experience in terms of the patient populations that they treat. And so when we needed to understand the differences in discharges home or practice trends for a neurological population versus a cardiac population versus an ICU population, these were the therapists who could provide those unique perspectives about those populations. Lastly, this group represented some diversity in terms of their experience. Some had been working in the hospital for more than 10 years and others for less than a couple of years. And so those varying perspectives and training and other factors that come along with varying experience levels meant that we could have kind of a rich discussion and understand the perspectives of multiple types of clinicians within our department as we sought to solve this problem. So the first phase of that learning health system cycle was P2D, or performance to data. So we collect a lot of data in our electronic health record. Specifically for therapy services, there are multiple fields that are standardized within our therapy flow sheets within our electronic health record. So we document a lot of things the exact same way across all encounters. And this is really an important characteristic of our learning health system. What is a little bit more challenging is identifying which of those fields are most pertinent to a specific problem. So we needed to extract these data, and we did that from our EDV, or the Enterprise Data Vault. But we needed to know which variables to pull. And that's again where our learning community came in. So in a series of several meetings, we met with the learning community to identify what needed to be done. First, our leaders made sure that we were getting data that aligned with the problem of interest, our health system's priorities. And then the clinicians played crucial roles here, where they helped us identify two things in particular: which variables were representative of their practice patterns. So we talked about a whole host of potential options, right? Is it how long you're with a patient? Is it how many completed visits there are? Is it how many visits are completed over a certain amount of time? Is it the quality of those visits? And if so, how is that quality reported in the electronic health record? The interventions themselves. So we had conversations like this iteratively through multiple meetings in order to understand which variables were available to us and which variables the clinicians felt were most important in understanding the relationship between what they did and helping patients to discharge home, again, focusing on our problem. These therapists also helped us to identify which patient outcomes matter. So we knew that discharge home was a priority for our health system, but we need to understand, how does that happen at the bedside? What other outcomes are you aiming for in order to help a patient discharge home? And how do you think you are affecting those with your practice? So that led to a series of discussions with the therapists in our learning community as a crucial part of our engagement efforts with them. We also engage with technological partners at this stage, mostly to facilitate data access. So you can imagine that there's a multitude of steps that go into getting data from the electronic health record into the enterprise data vault and then out of the enterprise data vault in a way to analyze them. And so we had a group of technological partners from our enterprise data vault team who were able to help us with that process. The second phase of a learning health system cycle is to go from data to knowledge, and we did that. This is the primary figure from a paper we published in 2022 as a result of this study. So what you'll notice immediately is that there's a dose-response relationship. You can see that as you see the dots go from closer to the line to further away from the line in all of these different populations. What I want to call out relative to that, though, is the variables that are here. So looking at the y-axis, you can see that the variable of interest is PT visit frequency category. So what this represents is the number of completed physical therapy visits divided by a patient's length of stay. And then that is standardized to a 7-day period. So this was a direct result of conversations with our learning community. Most of the therapists in our hospitals think about the plan of care or the number of visits I'm recommending for this patient per week. So this was a way for us to help understand per week how many visits were these patients getting. And that led to us representing the categories of PT visit frequency this way. And I should note, even that was a discussion. Should we look at PT visit frequency or duration of visits? And when it came down to it, our learning community felt like that the number of times they see those patients, how often they're in the room relative to how long the patient is there, was probably the best indicator of their practice relative to how often patients can go home. So that was the rationale for choosing that based on discussions from our learning community. And then you'll notice the outcomes, which was also informed by extensive discussion with our learning community. So of course, discharge home was an outcome we identified that was consistent with the goals of our health system, and also was consistent with what the physical therapist stated they are attempting to do. They want to help patients get to an optimal setting and to the setting that the patient desire most, and most often that's home. But in order to get home, these patients often need to have improved function because they've declined during their hospital stay or as a result of the illness or injury that landed them in the hospital. And so our learning community suggested that we look at improved function as an additional outcome. Now, patients can get better even without physical therapy intervention within the hospital. Their medical status improves. Patients can discharge home even without physical therapy intervention in the hospital. But we decided that if a patient both gets better and discharges home, then there may be some effect of physical therapy as part of that effort. And so we decided to do a third outcome, which was a composite outcome of both of those outcomes occurring together. And then I'll come back again, and you'll note that the relative risk, which in this case is a positive risk because it's the risk of going home, increases for all three of these outcomes as the frequency of physical therapy increases across our categories. So this was an important finding. However, for the sake of this presentation, two important things should be noted. One, what I've described relative to the learning community's involvement in selecting how we conducted this study. And then second, their involvement in actually publishing the work. So you'll note that Kelly Adams, who was the research assistant who was brought in as a full-time clinician, was involved in taking this study all the way through to publication, as was Mary Stilfen, our senior director. When you engage with health system partners, they should be engaged from the beginning to the end. They should be engaged in understanding the problem, creating new knowledge, and then they should also be engaged in the next step, which is going from knowledge to performance. So leaders and researchers collaborated at each of these steps in our path that were led from the publication of this paper up to actually changing practice, we hope at least in some ways, by creating a specific tool, which I'll describe. So in August of 2021, after we conducted the study, and as we were working on publishing a paper for external dissemination, we also presented to Cleveland Clinic hospital managers across our entire system. This was facilitated by Mary Stilfen, our senior director, and allowed me as the researcher to present the findings of our study. So we identified that across multiple types of patient diagnoses, patients get better when they have more frequent care. But that was a discussion then about, well, do all patients get better when we see them more? And in conversation with those managers, we identified that that's not necessarily the case, that there are patients who need more therapy to get better, but not all patients need more therapy to get better. And so that's really led us down a more targeted path as part of a separate learning health system cycle. For the remainder of this discussion, though, what also happened is a couple of months later, there became, amongst our leadership, a renewed discussion about value-based care and acute care PT, and how can we provide higher value care and how can we help clinicians focus on value, again, improving outcomes without increasing costs. So this led to a concept of a value dashboard for acute care physical therapy. The value dashboard has become an important tool for us to visualize various aspects of practice, including the number, frequency, and duration of visits relative to specific outcomes. And I'll show an example of the value dashboard here in a few slides. In July of 2022, we finalized a version of the value dashboard that we wanted to roll out to one of our hospital departments. And our managers, again, as the leaders of our department, opted to be the ones that rolled this out in discussion in department meetings. And in August of 2022, we held a department-wide rollout meeting of this tool. For the sake of demonstrating two things to you, one, how the value dashboard is part of our knowledge to performance solution, and two, to demonstrate that collaboration across our health system is really what we're trying to build. I want to go through just a few slides of that actual rollout meeting. So notice again that this was presented by myself as a researcher, Mary Stilfen as our senior director, and Maggie Magovich, one of our department managers. So this was a collaborative effort. In that presentation, we laid out to our clinical teams that the purpose of the value dashboard is to count something interesting so that we can learn something interesting, which is a quote from Dr. Atul Gawande's book, Better. Really, the purpose of the value dashboard, we pointed out to them, is to get better. It's really to feel curiosity, to help us identify ways to improve our practice, to improve patient outcomes. We explained to our clinicians that the value dashboard should be a catalyst for discovery. And so we presented this slide, which shows that the learning health system cycle would be slightly modified for the purposes of our use relative to the value dashboard. So what we expect is that the value dashboard will primarily inform discovery, that our clinicians will be able to review the data that's presented to them visually on the dashboard and interpret some results and try to understand what's happening in order to identify health problems of interest. And then once they identify those health problems of interest, we would kick in and identify a learning community to solve that potential problem. Note again that this can be done at the individual level, an individual clinician saying, I'm not quite sure why my results on the value dashboard are showing this way, or a team making that same discovery, or even a whole department making a discovery like that. And identifying at those individual levels or those separate levels, what the health problem of interest should be. And then from there, closing the learning health system cycle loop, where we then study that health problem of interest by capturing practices data, discovering specific things about that specific problem, and then designing interventions and taking action. So this is the value dashboard as we currently have it designed. So I won't take a lot of time to go through it, but note that across the top, each of our 6 clinical teams at one of our hospitals are represented, and this is actually a filter. So without any of these buttons selected, you're looking at the entire department. But as soon as you click one of these buttons, you can see how these metrics change for an individual department, or excuse me, for an individual team. And we're tracking those same 2 outcomes that we looked at in our study, the proportion of patients who discharge home and the proportion of patients who improve their mobility from month to month. You can see how we've got the sample size represented there on the bottom left, so that clinicians can understand how many patients we're talking about. And then we're looking at average minutes per visit, average number of completed visits relative to each month, and then those same metrics as we looked across various levels of AMPAC 6-click scores, where patients with a score of 6 to 10 have very low function, and those with 23 to 24 have very high function. So this graph on the bottom right helps us to identify the patients who are getting the most care relative to their functional status at their initial evaluation from a physical therapist. The second tab of this allows you to do see the exact same metrics, except it's at the level of an evaluating therapist. So the therapist now can see, for the patients that I evaluate, what proportion are discharging home or improving mobility, and how often are they being seen, and for how long, and what's the distribution of those metrics across 6-click scores. And then the third tab doesn't look at individual patients per se, but rather looks at individual visits. So a clinician, an individual therapist can select themselves, and they can see how many evaluations or treatments they've done in a given month, and also the distribution of their visits. So this 6 clicks plot does not represent just the initial score for a patient, but rather for every visit, what was the patient's score? And then the blue bars represent how many visits did I do for patients with those scores, and how long were those visits. So again, helping us to identify our resource allocation relative to patients' functional status. So we have several next steps associated with this project, because learning health system cycles should build on one another. It's not a single cycle, but rather it feeds into the next one. So our next cycle will continue to include both senior leaders and managers, and importantly, staff physical therapists. The particular problem, and we've actually identified several, but one of those problems that we are choosing now to study is, how does the VDASH influence care delivery and the physical therapy perspectives of practice, right? So we've created this tool, and we want to now understand, is it actually influencing or changing, hopefully positively, the practice of therapists in our department? We are collecting data using both surveys and, of course, electronic health record derived data to understand this question and this problem. And we will analyze those surveys. We actually have already done some of that work, and the electronic health record data, to observe if trends changed in treatment patterns and patient outcomes. And we expect that for our knowledge to performance, we will continue to build. So we actually had the opportunity to present some of this work at CSM just this past February. And we're working on updated versions of the value dashboard now to better represent some of the characteristics of practice that our therapists have asked for as they've reviewed the current version of this tool. We're also considering other value-focused and related department initiatives. How do we make the VDASH just part of our culture? Because it's a new thing and it's not something that a lot of therapists are used to thinking about. So we're trying to identify ways to kind of bake it into the culture and make it important to our clinicians, both by providing them the data that they think is most useful, but also creating a culture where focusing on those patient outcomes really is the center of what we do. Happy to address any questions. My contact information can be found on the LeaRRn website, and I'm happy to talk with anyone who has additional feedback or ideas relative to this work. Thank you so much.